A pioneer in cataract surgery. Please go ahead, sir.
Thank you very much, uh, Gaurav, for your kind words. Am I audible and everything is fine?
Yes, sir. Yes, sir. Please go ahead.
Indeed, a pleasure to have such international galaxy of speakers here. So I would say good morning, good afternoon, good evening, good night to everybody who is from various time zones. Well, I'll be talking about my present passion, and that is the use of the femtolaser assisted cataract surgery. Femtolaser cataract surgery, even in routine cases, is something that has caught on at least in the Delhi NCR capital. And today we are doing about 50 to 60%. In my personal cases, maybe 70 to 80% of my cases are being done by the femtolaser. But the advantage of the femtolaser comes into play when you're looking at complicated and challenging cases, and that is where you need to explore the power of femto as to how it helps. I have no specific financial disclosures for this particular talk, though I am a consultant for J&J, whose machine I'll be talking about. Well, femtolaser cataract surgery is, as I would say, a tool for the routine, but also to simplify the challenging cases. And something that has been talked about earlier is is my passion for doing femtolaser, as Mohan said, in all posterior polar cataracts. And even if there is a pre-existing weakness in the posterior capsule, the cortical cleaving hydrodissection, if done, which was done earlier, can cause hydraulic rupture. But the femtolaser assisted pneumodelineation that happens, it totally eliminates the need of doing a hydrodissection or hydrodelineation. And the disassembly of the nucleus, as was described by Abhay about concentric rings or segments, they can simply simplify. And this was the paper that was published regarding the femtolaser integrated anterior segment OCT to detect pre-existing capsular rent in Journal of Cataract and Refractive Surgery. And as you can see here, the conclusion was that femtolaser with integrated ASOCT is relevant and a helpful tool to detect and increase the safety margins. And this is what is very, very important that is there. I'll just show you that pre-operative imaging is what we are comparing with the intraop OCT just now, and in a thesis for a DNB student, and the results would be out soon. But here what I'll just wish to show you is that again, what has been shown is that this is clearly, you can see that this is a clear defect which is there. There is no posterior capsule which is there, and these bubbles that you get onto the catalyst system, you just have to raise the default setting, because you can see here that these default setting, and you have a clear area where you would not be doing anything to the as regards the femto, and you can see the ease of disassembly that you can have. And this is the posterior capsular rent that happens. I would wish to differ slightly. I normally do not, whether if I make it a posterior capsular excess, because these defects are vertical transactions which happen and they are pretty large. And I have had cases where the IOL is not stable. So I normally prefer to do a sulcus implantation with a 3-piece lens in this. So in this complicated case, of posterior polar, the femtodelineation definitely enhances the safety. The softening of the nucleus can help tackle even harder nucleus, as you saw in the previous case. And a perfect CCC is good for sulcal implantation. Kiranjit was talking the other day. He is describing the oval capsular excess, and he thought, and I think it wouldn't be difficult to get an oval capsular excess if somebody wants. You can have the machine give you an oval capsular access because they will have to open the software and allow you the same. Now, this is a picture of the Malignant ring that you can have for doing femtolaser assisted cataract surgery in a small pupil. Now, this is often sometimes said that you can't, obviously you can't do a femtolaser until of course you have an adequate pupil. So if a pharmacological dilatation is not possible, you can do a mechanical delineation or a mechanical dilatation of the pupil that is there. Now you can see in this particular case, you will have to go in and have to come back to the laser machine. So that is something which is important. So this is a Malignant ring that is being used. The pleasure to have Dr. Boris Malignant also in this session. And this again is a great innovation. So you can see that you get an absolutely well dilated pupil. You can wash away the viscoelastic and maybe put a suture, or you can increase the energy level. And you can see that this is a good capsular excess that is being done. There is a dissection that is happening in this particular case. So you can see that we have in a small pupil a good rhexis that can happen in these cases. Dr. Titial showed it as regards white cataract. The basic advantage of doing a femto in a white cataract or in intermittent cataract, in this particular case of phakomorphic glaucoma, is that you are working on a closed chamber. So you can see the swelling of the lens which is there in this particular case, and you can see the crowded anterior chamber where you have the iris. Almost you can see that it's a block, and again you can see that there is a gush of fluid that is coming out because it was so much liquefied. The important thing in all these cases is that even if you feel that there is no tag, you should always use trypan blue, because inadvertently there will be some tag which will be there, and the trypan blue will help you take care of that removal of the tag if at all that is there. Now, this is a rock hard cataract, mind you. This is a grade 4, grade 5 cataracts. I think David Chang also shows some of these cases where he goes on to SICS. Now, you can see in this particular case, the advantage of the femto, you can see that the cleavages have happened pretty well, and look at the color of the nucleus that is there. So harder the cataract, the more advantageous it is, as long as it is not white. If it is white, you don't get exactly good cleavages which are there. But if you have a cataract through which a slit lamp can see, so similarly a femto can go and penetrate through that, and you can see that we get good outcomes. Now, when you come to post-traumatic subluxations, that is an important area where you can actually use the power of the femto. The power of the femto can be used in doing a capsulorhexis, which you can decenter, which I'll be talking about, so that it becomes centered after you put the ring. Now, this is the case, as you can see. In this particular case, you can see the bowing backward of the iris. Can you see this iris? And it is going backward. So there is a subluxation, and there is, if you look very minutely, there is vitreous that is coming onto the top. So there is a subluxation with vitreous which is coming, and what we have to do is that the machine will not give you on the auto the posterior and the interior capsule, so you have to bring it back. Now, this was on a scanned capsule that you have, but we go on to a manual. I'm just going on a fast forward. In this particular case, we are using the pre-planned posterior approach. In this particular case, putting tricot, you went in with the posterior approach, did the vitrectomy to remove this with tricot, putting in endocapsular ring in this case, and you can see that the chopping has actually softened the nucleus pretty much, and without much intervention, you are able to bring out the nucleus with the power of the femto that has happened. Bimanual irrigation aspiration will help you in reducing, and then you have to actually peel out the cortex because there is an endocapsular ring which is already there. And once you have done this, keep the infusion on, as is important. Put viscoelastic, additional support to the capsule with a 3-piece intraocular lens, and again you can see if there is any vitreous tag or not. And this is the post-operative condition that you have in this particular case. So friends, all that I wish to say is that there are various indications for the femto machine that can help you in these difficult and tough cases. Obviously, this is not the last part. There are several others. You can do it in the pseudo exfoliation, gives you a good capsulotomy. Whenever the capsule is not giving you a good adequate support for doing a capsulorhexis, white cataracts, hard cataracts, as I told you, posterior polar cataracts. So things become much easier, and specifically it hastens up. One of the things that is being said about femto is that it slows you, but I actually, if you have a teamwork, you can have somebody else doing the femtos outside and you doing the procedure inside, or vice versa, and that actually speeds up the procedure. And my time has actually gone down by about 40% as regards the entire thing spent as doing multiple cases. So I think friends, as the only thing as is the technology, it is becoming cheaper. In due course, we are also having the Cassini, which should be introduced in India, where you can have a good alignment of the steep axis, which is there for LRI correction. I think if the LRI nomograms become better, then the LRI will give you better outcomes, and you can correct astigmatism of smaller degrees without the need of going in for a toric intraocular lens. I think if the cost per procedure goes down, it is going to be the standard, the gold standard, I would say, over the next couple of years as the procedure of choice for cataract surgery, and specifically for cataract surgery where you have issues of complications or difficult situations which are there for handling. Thank you very much for your kind attention.
Thank you,